Welcome to my world. Another day, another time, another period for knowledge acquisition. Knowledge is power, health is wealth. Today's topic has to do with TB and HIV co-infection interactions. The TB we know clearly depends on the survivor in the lungs. That is, if it's able to find its way to the lungs, and the body prevent TB from spreading using the cell-mediated response, and this goes a long way to contain it. At times, the TB could just conceal itself away from this cell-mediated response and stays there for years, many years, as latent TB. And then we now have the HIV, the human immunodeficiency virus, that goes about attacking this cell-mediated response, especially the T cells. The T cells that help present these HIV, the TB, so that the body antibody can quickly destroy it. But when this becomes the target of the HIV, you can suspect somebody who has the infection of both TB and HIV really having a serious problem, a synergic infection of these two very dangerous microorganisms. But it is far beyond that. The interaction between the two, it's really devastating on mankind, and probably explain why TB has not been eradicated up to now, as well as HIV. But let us not dwell so much on the periphery. Let's go into the slide section where I shall expose more detailed information. If you like my presentation, press the like button, subscribe. The objective: to create more awareness about the co-infection between Mycobacterium tuberculosis and HIV and the devastating effect of their interactions in order to meet the WHO target of eradication of these infections by 2030. Introduction. TB is a short name for tuberculosis caused by a bacterial genus, Mycobacterium, and the most commonly implicated species, Mycobacterium tuberculosis. The infection is as old as leprosy, caused by another species, Mycobacterium leprae, in its genus, and very deadly. According to L. Snyder, rate of death from tuberculosis in the United States decreased from 194 per 100,000 persons in 1900 to 40 per 100,000 persons in 1945, in part because the epidemic of tuberculosis in the Western world was running its course, and in part because of public health initiative and improved socio-economic conditions. So you can understand that in the past, TB was almost totally eradicated before the present scenario caused by HIV. In 1945, 63,000 persons died of tuberculosis and 115,000 new cases of the disease emerged. Streptomycin and para-amino-salicylic acid came. The discovery of isoniazid followed in 1952. So all these chemotherapy, that is antimicrobial agents, were able to suppress the growth too, apart from the social economic condition improvement and segregation. Yes, these drugs help to reduce the mortality and morbidity. And the U.S. government decreased funding immediately for tuberculosis, and many and this spiraled all over the world, where everybody started feeling safer. After 1984, the rate of new cases of tuberculosis, which had decreased to 9.4 per 100,000, began to increase, and focal outbreak of multi-drug resistant tuberculosis were reported. When you're talking of after 1984, you are talking of the beginning of HIV/AIDS. Non-compliance with drug therapy, homelessness, immigration to the United States from developing countries and human immunodeficiency virus infections were invoked as explanation. The emergence of HIV really could be the reasonable cause of this epidemic of tuberculosis. WHO has declared TB a global emergency in 1993. The prevalence of TB and HIV around that period, co-infection worldwide, is 0.18%, and about 8% TB cases have HIV infection. Yes, you can understand that TB precede the HIV infection. So, effective chemotherapy has been available for treatment of TB for over 50 years now. In WHO, International Union Against Tuberculosis and Lung Diseases Working Group Global Anti-Tuberculosis Drug Resistance Surveillance, 1994 to 1997, the incidence of multi-drug resistant TB in New Delhi was found to be 14%, of which primary multi-drug resistance was only 1.4%, indicating that most of multi-drug resistant TB is acquired as a result of poor chemotherapy. And one can understand that the chemotherapy is also very, very good. Yeah, let's now move on to lab findings. The research is done by various workers. One, HIV was found that it markedly increases the risk of progression to active TB. So if you have the HIV, there is the risk of progressing to the active TB, because usually you want to think of the latent, but in this situation, the latent is not even happening. It's active TB immediately, and the mortality associated with TB. So it increases even the rate at which people with TB die. Two, likewise, TB is a leading killer among HIV positive individuals. That's another finding. TB also aids in the progression of HIV disease, increasing the risk of developing other opportunistic infection. That's also additional. It's a synergistic infection, sort of, that it has worsened the situation of people who have TB and their co-infection with HIV. The third point is the influence of each infection on the other's natural history and pathogenesis has enhanced the magnitude of TB HIV epidemic. And the fourth is the prevalence of TB HIV co-infection widely varies. The prevalence of HIV among TB patients ranges from 3.8 to 72.3%, whereas the prevalence of TB among HIV positive patients range from 2.9 to 64.5%, and that is another finding by Gao, J, and his co-workers. Yeah, let us look at the interaction as regard drug. When you talk about trying to cure the patient with the drug, is it really causing drug interaction? According to WHO Global Tuberculosis Report and UNAIDS Global Report 2015, drug interaction between rifampicin and HIV non-nucleoside reverse transcriptase inhibitors and protease inhibitors pose the greatest challenge in the choice of ART, that is antiretroviral therapy regimen, for HIV-infected patients with TB. Rifampicin lowers concentration of nevirapine, evavirenz, and PI, which can result in loss of viral suppression and HIV drug resistance. Over the long term, this poses a serious problem for HIV-infected patients who may not have access to second-line ART. The use of rifampicin in place of rifampicin for TB treatment reduces the magnitude of this interaction. But do you think countries that are underdeveloped or developing countries can afford this rifampicin? Yeah, the control is a very necessary tool to minimize the impact of this co-infection, as exposed in the researches done by various workers. So early detection of either of the two is very helpful in longevity. And the BCG vaccine that is usually received by children or babies as they grow is useful. Then the TB skin test or mantle test can be done so that repeat tests will also help to confirm the increased size of the swelling to now probably indicate that there is a serious need for the vaccination or checking the X-ray test. The TB blood test is also more preferable, especially for adults, but not for children under 5 years because of the volume of blood needed. The nucleic acid amplification test is very necessary for both HIV and TB. It detects them very early. With the HIV, you use the gene experts and it will get it. You need to also do the viral load test and CD4 counts with HIV. There are other tests like the ELISA and what have you. For TB, microscopic culture is the gold standard, and the X-ray could also be used where there is that suspicion with the skin test or the blood test of TB testing. The sensitivity antimicrobial resistance is also useful for multi-drug resistance of TB. And with all these efforts, it will help in quickly detecting early what the patients harbor, and the treatment once it's begun with it really reduce the rate of loss of life as well as reduce the conversion to AIDS, and that is also one of the targets, the expectations. Yes, the culture can be done by starting with the ZN staining on pre-specimen. We pull them together and culture them by trying to concentrate them. You digest, centrifuge at 3,000 rpm for 15 minutes. Supernatant is discarded and sediment neutralized with using phenol red as an indicator. 2 to 4 loopful of the sediment will be inoculated into low exigency medium, a very good medium. There are other egg yolk mediums and even modern mediums, newer mediums these days. And the sensitivity for MDR could also be done. Yeah, finally, conclusion. It is a known fact that malnourished people are easily predisposed to tuberculosis, and Harrison really confirmed that the depletion of monocyte, which is used in cell-mediated response, which I had earlier mentioned. HIV-infected people are already immunocompromised as the virus, and from the researches, we have been able to prove that once a person is infected with HIV, it also helps quick the TB to really devastate the body and progress to death, which probably not having the latent period where the TB hibernates somewhere. So early treatment of both, therefore, will surely aid in recovery from tuberculosis and reduce the rate of conversion to AIDS. The target of WHO that the eradication of both by 2030 will become highly successful. So, and 2030 is very close by. The reduction is not something one can say is encouraging in developing countries, especially with the economic situation of the world right now tending towards recession. Like I said, you can always see so many health programs on this my channel. Ask Akinola-Anjou. Thank you.